Hello, I'm Dr. Fan from National Taiwan University Hospital. It is the biggest public and oldest hospital in Taiwan. After Dr. Koo talked about supraglottic airway as a rescuing airway, I try to extend its application. As we know, when Archie-Brain invented the supraglottic airway, the air may only be used in a short duration and simple operation. But the new second generation supraglottic airway, especially today, I try to highlight the aura gain from Ambu company in the laparoscopic pneumoperitoneum and a transdental position even in most challenging obese patients. I have nothing to disclose about this webinar. ERAS, the so-called enhanced recovery of surgery, is the common goal for modern surgery. There are many ways to improve this goal. For surgeons, they have shifted most traditional surgery into laparoscopic operation. And we anesthesiologists know supraglottic airway is less invasive than traditional endotracheal tube. But SGA is compatible with this kind of operation when surgeons infuse a lot of gas into the abdomen to increase the visibility and also put patient in head-down position, so-called transdental position. It is possible for supraglottic airway. And how about the second generation? I and a lot of people like the British famous band, the Beatles. And we have found Paul McCartney, it looked like Archie-Brain, the inventor of supraglottic airway. Actually, they are in the same age. Interesting. In 1980s, Archie-Brain have an interesting idea. Can we make traditional facial mask smaller enough and can insert inside the mouth and just cover the laryngeal outlet? He tried many devices and material, and finally he found the dental nose for dental patient maybe fulfill the purpose, and it became the prototype of supraglottic airway. This is the first video clip to show how to insert supraglottic airway into the patient. We have observed the Archie-Brain insert the supraglottic airway into our old patient. Use his left hand, but the tooth is Arch is left-handed. This is the first commercial supraglottic airway, the laryngeal mask airway. It is one of the most important inventions in the history of anesthesia and expand the application of airway management. After its usage for almost 20 years, we have observed a lot of defects. Because the tube is so soft, you need your index and middle finger to facilitate the insertion, and the cuff seating pressure is not so good enough. And the cuff also easily be forward together and obstruct the airflow. You need another bite block to prevent the biting of the soft tube and block the airflow. Dr. Brain is also my friend. He has visited Taiwan for several times. Arch himself also knows the defect of the classic laryngeal mask airway, because the inadequate seating for 15 to 20 centimeter waters around the larynx will induce the hyperventilation and the gastric insufflation, and leading to regurgitation and aspiration. And because the soft material prone to displacement of the devices during operation. Because the concern of the classic laryngeal mask airway before the retirement, Dr. Brain invented the laryngeal mask airway procedure, the first second generation, with the common feature of gastric channel. They can drain the gastric content and prevent the aspiration. And because the second generation procedure has a higher seating pressure up to 30 centimeter water and can provide a better positive pressure ventilation for longer operation. But because these devices are reusable, they need to be sterilized before its usage. And these devices, the price is higher, and you need to plus the cost of the sterilization. Because the pandemic infectious problem like SARS or COVID-19 nowadays, let us worry about the safety of reusable airway devices. It is the reason why the disposable second generation supraglottic airway and gradually become the mainstream. In 2015, the Difficult Airway Society with the Society of the Airway Management combined proposed a new algorithm for difficult intubation guideline. They simplify the algorithm into 4 planes: Plane A, Plane B, Plane C, and Plane D. Plane A emphasizes on the laryngoscopy. If fail, they will skip to Plane B by supraglottic airway devices. If still fail, they will wake up patient by facial mask, the Plane C. If still fail, they will direct to cricothyroidotomy, the last plane. But because the second generation supraglottic airway devices is so effectively and very easy to be used, is it possible just skip the Plane A and direct to Plane B? As my routine usage in a teaching hospital, nowadays more than 80% of my cases are direct go to the Plane B instead of Plane A. 4 years ago, we published a paper. We compare IGL with endotracheal intubation in patients receive laparoscopic operation with pneumoperitoneum and transdental birth position. We have found in supine position, the endotracheal intubation is a little bit better than the IGL because the leaking fraction is 6% instead of 7% from IGL, but in transdental position, they're almost the same. We propose maybe the intra-abdominal pressure from visceral organ and intra-abdominal gas push the diaphragm and indirectly make the supraglottic airway devices and the laryngeal outlet more fitter. So we conclude IGL is a good alternative to this kind of operation. In the following slide, we will show the new oral gain from the Ambu company may be better, even can be used in an obese patient. This is a paper from Current Opinion Anesthesiology 2015 and review the new second generation supraglottic airway devices. And from this paper, it described the new devices can be used in a lot of situations, including the laparoscopic operation. To successfully use these devices in laparoscopic operation, the supraglottic airway at least 8 cm water above the peak inspiration pressure under normal ventilation, and at least 25 cm water for the seating pressure. And for our second generation airway devices, most of them achieve this goal. And the paper show for these devices, they can be used for extended indication, such as prolonged procedure and laparoscopic procedure, obesity. Even in prolonged position, they can provide and serve for most of the purpose. The new second generation supraglottic airway devices, or again from Ambu company, it is disposable airway devices, and they have the seating pressure about 30 cm water, and also have a lot of extra benefits I will show in the following slide. To effectively insert the second generation airway devices, you need to know the different features of the devices. Unlike Oragen or Supreme, iGel is a straight airway devices, but it is flexible in the mid portion. So iGel is very easy to be inserted and can be angulated according to the shape of the patient airway, but it also easy bouncing out if without adequate anesthesia or skill. Unlike iGel, Oragen and Supreme has a preformed L shape, but Supreme is very rigid in the angulation. However, Oragen is much more flexible. So if there is a problem of the tongue obstruction, it can be easily rotated and inserted into the proper position. But Oragen, because the rigid angulation part, so they cannot easy to be rotated. Another benefit of Oragen, because it has the largest gastric channel. You can see my demonstration. It very easily to insert a French 14 suction tube instead of 12 for iGel and Supreme. Recently, I and my colleagues do a research comparison of the efficacy of supraglottic airway devices and do a network meta-analysis. We collect more than 6,000 papers and exclude the papers, the supraglottic airway devices, by inexperienced anesthesiologists, and exclude paper without clearly designed, without randomized. So finally, we only include 109 good quality paper and compare different domains of these devices, including the oral leaking pressure, the first attempt failure rate, sore throat, and so on. From this figure of forest plots of network meta-analysis for oropharyngeal leak pressure, we found Protect Oragen are among the best for the seating pressure, The standard is the classic laryngeal mask airway. For protector and oral gain, the new supraglottic airway devices is about 9 and 8 centimeter waters above the classic laryngeal mask airway. For oral gain, is about around 4 to 12 centimeter, and protect is about 6 to 12. The ideal is 4 centimeter above the classic laryngeal mask airway. So for the most recently second generation is much better than the classic laryngeal mask airway. And when we compare the risk of sore throat, oral gain is the best. The standard also the classic laryngeal mask airway, and oral gain is only 0.23 of the standard. So if the classic laryngeal mask is 1, the oral gain is only 0.23. So it's less sore throat than the classic laryngeal mask airway, although because it's a new, so the standard deviation is still a lot. And for the insertion failure, LQ Ambu is also much better than the traditional classic laryngeal mask airway. The following slide shows a patient in a transdental position. This patient is under laparoscopic surgery for chocolate cyst and use neuromuscular blockade for the relaxation. For laparoscopic surgery, I think we also agree NMBA is very important for the relaxation of abdomen muscle and the easy of operation. Oral gain also can be used in a pediatric patient effectively. For my personal experience, the least body weight is 2 kilograms, and for this slide, the baby received herniorrhaphy is 6 kilograms without neurovascular blockade, but I also add quarter block, and the operation is very smoothly. We will see the following video clip later. Teaching hospital like my hospital is very dangerous for patient because there's a lot of learner. The new learner try to intubate you. They are not the A team, but the B team. So a good airway devices must be very easily learned and provide a very satisfactory airway for the patient. And you need to know the basic physiology and pharmacology of the airway anatomy, because to successfully put airway devices, you need to prevent a lot of reflex. The 3 major reflex for the airway devices is gag reflex from nerve 9, and cough reflex and vomiting reflex from nerve 10. So you can use inhalation to abrupt this reflex, or you can use high dose intravenous drug like propofol. Of course, you also can use neuromuscular provide to prevent this reflection. To successfully insert, you need to know the resistance during insertion in different parts of the airway. For the nasal mouth opening, you can use a proper size and proper depth of anesthesia and flatten the cuff at the insertion. For tongue obstruction, you can use jaw thrust or tongue retraction with thumb or tongue depressor, or even you can use laryngoscopic braid. For a tonsillar pillar, you can rotate SAD for oral gain and a proper lubrication, etc. To successfully and effectively insert the second generation supraglottic airway devices, you need to know the features and the materials of these devices. These three are the most popular airway devices in our department, including Oral Gain, Supreme, and iGel. Oral Gain and the Supreme already have L shape, and iGel is a straight, so iGel is very easy bouncing off of the mouth if the iGel without securely tapped. And Oral Gain and Supreme has a preform angulation, but the Supreme is very rigid and Oral Gain is much more flexible. So Oral Gain can be straightened into the laryngeal outlet easily from the outside of the laryngeal tongue to prevent the obstruction of the tongue. I will show it in the following video clip. The following video is our second year resident rotated to the pediatric section. It's the third time to use the Oral Gain, so the resident rotate from the child side of tongue and rotate to the proper position. And the patient without neuromuscular blockade, the patient reflex are blocked by the inhalation sevoflurane without use the neuromuscular blockade. The following practitioner is the PGY student. It's the first time to insert the Oral Gain into the adult patient receive laparoscopic operation, and it also rotate from the side of the tongue into the proper position. It seemed not so difficult for the beginner. To successfully put the supraglottic airway and achieve the optimal seating pressure, you need to select the right size. Not only consider the body weight, but the ideal body weight. You need to measure the distance from the base of the tongue to the opening of the esophagus. To measure the distance is equal to the A distance. You can measure the distance before select the proper size. To successfully insert the supraglottic airway and achieve the optimal seating pressure, selection the proper size is very important. For morbid obese or severe obese patient, selection the size must depend on the ideal body weight and the length from the base of the tongue to the opening of esophagus to measure the distance. For this patient, the body weight is 100 kilogram and body height is 161. BMI is 38.9, moderate obese, and I select size 5 instead of size 6 from the labeling suggestion. For this morbid obese patient, the patient body weight is 105, but it's very short, only 156. The length between the esophageal opening and the base of tongue is very short. Although the BMI is 43.2, I select the size 4 instead of the size 6 if you only considering the body weight. So for this obese patient, you need to measure the distance beforehand to achieve the best seating pressure. This is the last video clip for the demonstration of the oral gain for a laparoscopic patient. The reason is the third time to use oral gain. It seemed not so difficult for the reason. I'll insert the oral gain. We tap the oral gain securely. Under the transcendent position of the operation, after finishing operation, you can put a gastric channel, the suction tube, and you suction out the gastric content. In the same time, you can take the oral gain out of the patient. The take-home message for this lecture is the second generation's supraglottic airway devices can be used safely and effectively for surgical patients in laparoscopic, pneumoperitoneal, and transcendent position. And the oral gain is very easy learned, and the moderate patient and children can also be used safely. But patients with low airway problem or severe lung disease and intestinal obstruction should be avoided. Thank you for your attention and welcome to Taiwan.